hopes of staying on track. So we're going to hear today a little bit about clinical olfactory research, specifically geared towards updates on COVID-19 related smell loss and recovery. And I will give you a little general introduction. We are the Global Consortium for Chemosensory Research, and what we do is we've been researching the loss of taste and smell in COVID-19. We have a couple of publications about that, and you can read about that on our webpage. And there's also some plain language summaries there, which will hopefully make the research a little bit more accessible. And you can use this QR code to get to the webpage. We also create resources. For example, we're working on a global database with clinicians that have expertise on taste and smell disorders, so that in any region of the world, people can try to find their closest clinician with the right expertise. And we also have webinars online that you can look at. We're also doing global basic research studies. For example, right now we're doing a big study with sugar solution preference testing in 62 labs across the world. Just a little household announcements about the webinar. So we'll have 2 speakers. There will be time at the end of each talk to ask questions. How can you do that? Well, you can virtually raise your hand with the raise hand button. And then if the host gives you the opportunity to talk, you can talk. And if you want to lower your hand, you accidentally raised it, just press that same button again. You can also type in the chat during the talk, and then we'll get to your question at the end of the talk. Just keep an eye out on, you can, direct your chat message to everyone, which is great for questions to the speaker. You can also just direct it at the host if you wanted to ask a question anonymously. But you can also use the chat to chat with other attendees, but I would recommend using that sparingly because it's saved automatically. So just so you know. So if you want to watch this webinar later, or you want to watch other webinars, you can always go to our YouTube channel, and this is the QR code for that. So why is Anosmia Awareness Day so important? Well, awareness of anosmia is important because in general, the sense of smell is undervalued. So there was a recent study done by a group of researchers that is also in the GCCR, but this was done in a collaboration with International World Taste Smell Day. And they asked participants in many countries, when you have to choose one sense to lose, which one would it be? And then 64% of people are actually willing to lose the sense of smell. However, we know from COVID-19 that a loss of sense of smell actually profoundly affects every area of life. So there are currently an estimated 15 million worldwide with long-term smell or taste loss, whether that is from COVID or other causes. And this is connected to health and well-being, and more research is necessary. So it's important to continue to ask for attention to smell loss. So today, the outline of this webinar will look like this. We're going to hear from Professor Carl Philpott on COVID-19 related smell recovery. Then we'll have 5 minutes for questions and answers. And then we'll have a little introduction for Dr. Braima by Daniel Wang, and then her talk on a clinical approach to a patient with chemosensory dysfunction, and then again, time for questions. So I will now start with the introduction for Professor Carl Philpott. So Professor Philpott is a professor of rhinology and olfactology at the University of East Anglia. He's also a honorary consultant ENT surgeon at James Paget and Norfolk and Norwich University Hospitals. And I'm looking at his resume right now, which is a very impressive resume. He has won many prizes and awards, including most recently Bronze Clinical Excellence Award in 2019. And he has a bunch of notable positions. He's, for example, the trustee and director of research and medical affairs at the patient advocacy organization Fifth Sense. He's also the president of the British Otorhinolaryngology and Applied Sciences Research Society. Sorry, the words are always still difficult for me. And then also he's an associate editor at Clinical Otolaryngology and an editorial board member of Rhinology. He has an active research portfolio with various clinical trials and an extensive list of important publications on the subject. So I'm very excited to introduce him, and I'll give him now the opportunity to speak and share his screen, I'm thinking, and I will stop sharing mine. Thank you so much for coming here. I will do quickly still another couple of thank yous. Thank you so much, Jingguo Chen, for organizing this webinar, and also Dr. Braima for accepting the invitation to speak here, to Daniel Wang, who is also helping to organize this webinar. And thank you so much, Professor Philpott, for speaking here today.
Okay, well, thank you very much for the introduction. Sorry for all the tongue twisting things you had to read off there. Now let me just share my screen. Is that all appearing okay? Good. Okay. Right. So my brief was to talk about COVID-19 related smell recovery. So I'll just sort of go through where we are with sort of prevalence, have a look at the symptoms that we're seeing persist, and also in relation to long COVID, have a look at the rates of spontaneous recovery, and also things we might do to aid recovery. So COVID-19, obviously, well, I guess it's been the thing that helped bring the GCCR together in the first place. It's been a viral monster for the sense of smell, but I guess it's had maybe some positive things have come out of it. So what is the risk of olfactory dysfunction with COVID-19? We've seen that this has got sort of less over the time of the pandemic. Certainly with the early variants, we were seeing as many as sort of 2/3 of people were affected.
Currently, we're looking at the presenter view right now,
okay.
and not at the normal view, but that's not
better?
super relevant. Yes.
Yeah. Okay. Good. Right. So as I was saying before, we were really interrupted. We've seen sort of decreasing impact with the sort of variants as the pandemic has progressed. And this may be explained by the difference in the ability of the variants to damage the olfactory mucosa. So it's been 3 years now since the pandemic started, and so you know, in the pre sort of pandemic era, we used to talk about viral smell loss, and we were referred to often to a paper by Reardon et al. That looked at recovery from post-viral olfactory dysfunction and suggested that 1 in 3 over a 3-year time period would get spontaneous recovery. So we're getting to that stage now where people are starting to say, okay, well, you know, it's 3 years out, so what's the recovery looking like for COVID? And I guess it's still relatively early yet, because obviously as the next year goes around, we'll start to kind of get more of that data as people do move into that 3-year time window. But this paper documented 2-year follow-up, where an altered sense of smell or taste was reported in 11%, with 9% of those having had improvement and 2.5% with unchanged symptoms. And if we extrapolate that to sort of UK data, and we look at the sort of population of the UK, which is sort of over 67 million now, we can see that that equates to approximately 1 million cases in the UK, if we sort of extrapolate that fully. So that's sort of 10% at 6 months and 7.2% at 12 months reporting issues respectively. And on a global scale, there's probably over 20 million people affected, given the numbers that we've seen affected by the pandemic. So will it get better by itself? Well, the evidence so far sort of shows recovery rates varying from 32 to 95%. And there is some suggestion that improvement seems to depend on the initial severity of the olfactory dysfunction, with poorer performance in anosmic patients and better prognosis in younger patients. And I guess one of the revelations for me as a sort of clinical practitioner seeing patients with smell and taste disorders is that having to establish a paediatric clinic for patients coming through, particularly teenage patients, and mostly I would say teenage girls that have been presenting with olfactory dysfunction. So the recovery really depends how you measure it. And of course, one of the problems, as we all often know, with the sense of smell is the sort of difference between subjective assessment and objective assessment. And I guess the one bit of clinical practice where there is some better correlation is with patients with sinus disease, where they've got other symptoms to measure it against. But with other forms of olfactory dysfunction, such as with COVID-19, people's ability to kind of correlate where they are and how they. So this study looked at sort of sniffing sticks, so of patients that had suffered for at least 20 days out, and found a sort of a variety of range from non-osmic to anosmic. And in their study, most patients recovered within 2 months, but 1/5 were still experiencing symptoms 4 to 6 months later. Another study looked at upsit testing in 112 patients. Again, you could see this was at 6 months and at a range from normosmia in 40% to anosmia in 5%. We've looked at some data recently, which we published in the International Forum of Allergy and Rhinology, which was data from the Office of National Statistics in the UK, looking at people who were reporting symptoms of long COVID. And we were then able to extrapolate out ENT-specific symptoms, including those around smell and taste. What we generally found was it was adults aged 35 to 49 years that had the highest estimated prevalence of long COVID. So women with long COVID were at higher percentage rates of reporting than men. Now, of course, we know there's often a bias towards women being more likely to report olfactory dysfunction than men. Generally, that's something I see in clinical practice. And we can see here on this data that loss of smell came up as the third most common of the symptoms we looked at. So 31% of those reporting at 12 weeks, up from those reporting at 4 weeks. And then loss of taste is down there at 23% at 12 weeks after COVID infection. So, of course, the GCCR has been doing its own work and has had a study that started at the beginning of the pandemic, and then, of course, participants were invited to come back and provide more information. And this was the third publication from the GCCR that looked at particularly around some of the long COVID issues and the issues of parosmia and phantosmia. And so what we saw was that although at the beginning 10% were reporting parosmia, at the follow-up, which was at least 200 days, 2/3 of those who were sort of not reporting recovery from smell loss had parosmia, with just around a quarter of those who say that they were recovered reporting parosmia. And we can see there the sort of odds ratio for parosmia being 5.56 and for phantosmia 3.35. And we use these terms hauler and long hauler, which I have to say makes them sound like truckers, but for the want of better terminology, this was obviously the people essentially with the long COVID reported these symptoms, and we can see that on the next slide. Not only did they report these smell and taste issues, but brain fog, hair loss and memory loss were also commonly reported in these particular patients. So parosmia has obviously been a key thing that's been a sort of problem part of COVID-19. And recently at our clinical olfactory working group in Varese last October, we debated a lot of the terminology, and this is our kind of agreed sort of terminology for parosmia, being a distorted odor perception in the presence of a triggering external source. We've chosen not to kind of dwell on the term cacosmia, which is thought to cause confusion. Why does parosmia occur? Well, there's been various theories even before COVID came along around peripheral and central theories. And there's various kind of theories of how that might work in practice at a peripheral level. So is this about incomplete cell regeneration, leaving a sort of gap in the olfactory map at a receptor level? Is there some issue around incorrect wiring or wiring to the wrong glomerulus? Or is even this idea of sort of ephaptic firing, where there's a short circuit transmission between neurons? So all of these have sort of been put forward as potential theories. And of course, we know that most of the things that we smell are mixtures. And therefore, if we're missing kind of parts of a mixture, then we may be missing pieces of the jigsaw. And this is a kind of sort of very simplistic representation of the olfactory epithelium with receptors lined up and the traditional lock and key mechanism. And if we knock out some of the receptors, then obviously that reduces the ability of us to kind of pick up the complete mixture as it's represented. And of course, we then get sort of the action of the interneuron activity in the glomeruli, which may sort of downregulate things further and have an impact on the signal that's generated. But of course, what we've also seen, and this particularly came out of the UK Biobank MRI study, was evidence of central effect of COVID-19. Now, this was a group of patients who had voluntarily had themselves committed in terms of their medical detail to the biobank, and they'd also had some pre-COVID MRI scans. And some of these were invited to come forward and have MRI scans repeated post-COVID. And what was interesting to see was that there were changes in certain key areas, particularly the anterior insular and other areas that are involved in the central processing of disgust. And that brings out, is there another mechanism here in terms of how we perceive these signals, and therefore how this influences parosmia? And I guess on a positive note, there is evidence that parosmia is part of the recovery process, and certainly when I'm talking to patients and they're troubled by the issue of parosmia, trying to explain to them that actually this may be an encouraging sign that actually some olfaction is working and things may be slowly moving in the right direction, even though it may be a difficult phase for them to get through. And evidence as part of this publication was that olfactory training in those with parosmia can just be as beneficial as those with quantitative olfactory dysfunction. Of course, there's the issue of did COVID-19 really cause problems with true gustatory function? And of course, one of the big problems, and we've had this with the GCCR work as well, is that when you're asking people to report taste issues, with all the best will in the world, and no matter how carefully you word the questions, you will get people who report taste because of the colloquial issues we have, certainly in the English language, with taste and its kind of use for flavor perception. And it's only really when you actually apply psychophysical testing you can get a sort of a clearer picture. Now, this self-reporting studies you hear sort of showed that there was complete recovery of gustatory function and a higher percentage than olfactory function. I was involved with a small study where we had 10 people with COVID-19, 10 people with previous viruses and 10 controls. And in that small data set, doing psychophysical testing, we could see that there was a taste deficit in those with COVID-19 acutely. But it's a very small sample, and obviously it's difficult to extrapolate that to a much wider population level. So, yeah, can the sense of smell be restored after COVID-19? Well, certainly, even before COVID-19 came along, we had good evidence that olfactory training, and particularly modified olfactory training, was giving sort of benefits in terms of recovery. It's certainly not a panacea for all cases, but it's a very harmless sort of approach that can be taken by patients who are suffering with this condition. And a more recent publication has looked at this specifically within COVID-19 and seen benefit. We're currently working on a digital sort of version of smell training. We had started off calling the project iSmell, although our patient feedback at our first meeting a couple of weeks ago said that that probably wasn't the best term to use, and we may well change the name for the project in response to their feedback. But this is going to be sort of getting user feedback from using a device that will be taken by participating patients to their households and get their interactivity with it using an app, where they'll actually kind of deliver smells and get feedback on their performance on a daily basis. So that work is sort of in progress at the moment. In 2021, as a clinical olfactory working group, we decided it would be useful to kind of give some sort of review of what treatments were out there that had any evidence base behind them at all, and to give some summation of that. And that led us to sort of say that we would definitely recommend smell training. We would consider items in the middle, such as vitamin A and sodium citrate. And there were things that we should not consider. And I'll touch upon the issue of the steroids in a moment. We also sort of came up with some flow charts for managing these patients, both in a primary care setting to guide GP colleagues and in a secondary care setting. And specific comment here about sort of steroids. Now, there's been much debate about steroids. Should they be given? Do they have a use? The evidence really around them is still controversial, still unconvincing. I'm a sort of an author on a living Cochrane review for interventions for post-COVID-19 olfactory dysfunction. And the studies that come in have been sort of either small or contradictory. So our general philosophy as a group was to say, if patients have other nasal symptoms, then it's worth a trial of steroids, or if you see specifically on endoscopic examination evidence of inflammation. But if neither of those exist, then there really isn't a rationale as things stand for applying steroids in any form, and therefore move on to other treatment modalities. And what other treatment modalities are there? Well, we're currently doing some work through the Apollo trial on vitamin A. This was following on from work by Thomas Hummel that was done in Dresden in a non-randomized trial that suggested benefit in this patient group. So we're trying to deliver sort of some more objective evidence, looking at olfactory bulb volume as our primary outcome measure for patients before and after intervention. We're also doing some observational work on tumor necrosis factor alpha antagonists. And I've seen the work by colleagues on plasma-rich protein injections, which is yielding some interesting results, although still requires a randomized controlled trial to underpin that. And I think that's one of the key things in this area, is that, you know, in many of these things that have been tried before, we are still lacking in a large number of good quality trials. And so one of the bits of work we completed just over a year ago now was to do a priority setting partnership to try and establish research priorities. And through our charity Fifth Sense, then converted that into some research hubs, which we hope will help to drive the research mission forward going forwards, because particularly in the area of clinical trials, there is still much work to be done to provide good evidence for treatment. So at that point, I will stop there and invite any of you that are interested to tune into our 2-day symposiums on taste disorders, and thank you for your time, and welcome any comments.
Thank you so much for your talk. Currently, I see no questions in the chat, but maybe somebody would like to raise their hand and ask a question. I have a question in the meantime. It seems pretty clear that for now, olfactory training is the best recourse. I am currently unaware of, are there a lot of variants? Is there work on, you know, testing what is an optimal way to do the training? Do you have any insights on that?
Yeah, I mean, I think, you know, the previous work on the modified olfactory training showing that changing the odors every 3 months gives sort of greater benefit. Certainly seems to kind of bear fruit in my experience in practice. But it's about engagement with that, and obviously depends on how adversely affected individual patients are, and every individual person has to kind of learn how to engage with it on their own merit. And I guess that's why, you know, doing this digital smell care project, we feel that, you know, if we can help engage patients in the process of smell training through feedback through an app, actually, and potentially involving them in a wider community of people who are also doing the same thing, that is a sort of better way to get people sort of engaged with the process, because I think you can go into semantics about the individual odors used and the delivery method of those used, and there are pros and cons to that. Ultimately, if you keep things cheap and simple, obviously it makes it easier for people to get hold of and do these things. And so that's why I'm sort of always cautious to discourage patients from feeling the need to kind of buy any particular equipment. They should be able to use what's available to them in the home environment, in theory, as a starting point. If they want to buy equipment, they can obviously do so. It'll be interesting, obviously, to see if we find using an app and this sort of device beneficial, whether any costs around that become prohibitive and discouraging for individual patients.
And we have two questions in the chat, actually, from Laura Speech. She's asking, in the digital training, what does the device measure? Threshold, detection, discrimination?
So at the moment, it's specifically not a measuring device, it's a delivery device. So what it does is sort of to fire out the, it has 6 odors preloaded into it, and which fire out in turn. And then the app asks the patients to identify from a choice of options, and also it can sort of give them some feedback on pleasantness rating and intensity rating as well. But we're working on with patients on getting sort of their input on those particular things they want to see in the app.
And another question, and this will be the last question before we go on to the next, otherwise we will run late. Is stellate ganglion block being used in Europe for parosmia? And this is a question by Eric Holbrook.
Thanks, Eric. I think you've just sent me a review on this one, haven't you? So, to my knowledge, no. I know that Duncan at Fifth Sense asked me to sort of my thoughts on something he'd seen on this, and was concerned that people were using it as a go-to option. I haven't come across any patient that's tried it. I don't know anyone who's recommending it, so I don't have any kind of personal experience for it. I'm not sure I understand fully the scientific rationale for it, but I need to sort of have a look in detail and read what has been done on this so far to get a better thought on that.
And there are a few more questions in the chat. Maybe you want to look at them, you can answer them, but in the meantime, I'm going to ask Danielle to continue with the rest of the webinar. Thank you so much.
Hi, this is Daniel. Now we have the second speaker, Dr. Ogogo Brima. Dr. Ogogo Brima, she's an ENT head and neck surgeon with a total of 11 experience in the private and public health sector in Nigeria. She had a Bachelor of Medicine and Surgery from University of Benin in Nigeria. And then she got a fellowship in Faculty of Otorhinolaryngology in Western Africa College of Surgeons. And she's currently a member of the Royal College of Surgeons of England. And she's also the recipient of American Head and Neck Society Endocrine Sector Young International Female Scholarship of 2020. There's a lot from her CV. But now she's currently a specialty doctor in the ENT at the Countess of Chester Hospital NHS Foundation Trust in England. And she's also a adjunct lecturer at the Department of Surgery at the University of Benin, Nigeria. And also she's a leadership, GCCR leadership team member. So now I'm going to give time to Dr. Ogogo Brima for her presentation today. The title is Clinical Approach to a Patient with Chemosensory Dysfunction, Lesson from COVID-19.
Thank you so much. Thank you, Daniel. I will try to share my screen now. Okay. Thank you so much for having me. It's a pleasure to be here today. So talking about clinical approaches to the patient with chemosensory disorders, I thought the way to go about this would be to examine clinical guidelines and influential papers in the field over the last few years and see how that has progressed or how that has changed with COVID-19. As you can imagine, that immediately puts the sense of taste and chemostasis to a slight disadvantage. The vast majority of publications are around the sense of smell. So without doing any hard work at all, just looking quickly at PubMed, you find this spike of research in the last 3 years following COVID-19. And I think the question on the minds of most researchers is what has changed? When you do research, especially in respect to human medicine, you actually want to see this resulting in change for the patients. And so far, is this happening? So the first paper I would look at is in 2011. This paper was a guide for secondary care doctors, doctors in oral medicine, who would be seeing patients with taste disorders. Now, all the papers we're going to look at today, because they are clinical guidelines, they all give history and examination guidelines. So what to ask when you see the patient, how to approach the patient is constant across the papers. So I'm not going to go into that for each paper. What is interesting in this paper is the fact that they did recommend smell testing, and they listed out criteria for referral to ENTs and gastroenterologists because they appreciated the fact that the loss of one of the sense, in this case smell, could be misinterpreted as a loss of taste when in reality it actually is flavor. And they also talked about the role of counseling for the patient. In 2011, the European Academy of Allergy and Clinical Immunology released a paper describing diagnostic tools in rhinology, and this paper was directed at ENTs. In this paper, smell testing was recommended for patients who present with smell loss. And I know it would be like, that's a no-brainer. Of course, it should be. As we progress, you see that that's not always the case. And for taste testing, they recommended electrogustometry as the gold standard for assessing these patients. This paper in 2013 was from the US and in many ways was ahead of its time. One of the reasons I say that it's a paper that was directed at primary care. So what we see for a long time, what has usually happened is the patient presents with smell or taste loss to the primary care practitioner, and they're automatically referred onto secondary care to see an ENT or an oral medicine specialist without much being done in primary care. And this paper tried to tell primary care practitioners, you can do something, give the patient a questionnaire, try and gauge what they've lost. And then you can do a quick, short screening test for these patients to establish a baseline of their olfactory function at that point. If you suspect any underlying cause, you can treat. And very importantly, they recommended that you can start olfactory training from primary care before you refer to secondary care. This is perhaps one of the most influential papers around that time for olfactory dysfunction, the position paper, which was released in 2017, and it spoke extensively about subjective evaluation of olfactory disorders. As Professor Philpott had mentioned, subjective evaluation doesn't always reflect what you find when you actually do testing. But I think it's important in terms of talking about patient-centered care and getting the full picture of how this patient is actually impacted by the loss. And that was discussed in detail, including visual analog scales and other quality of life measures. But what was interesting in this paper is that smell training was optional. In the paper, you can do smell training, in fact, was the recommendation at the end of that paper. So the last pre-COVID paper I will look at was already mentioned in the previous conversation. This paper originated from Japan. So this is from the Japanese Society. And one of the most important things about this guideline is they actually received public comments in the developed treatment of this guideline. There's been a lot of conversation around, the process of developing clinical guidelines, and there are people who believe that public comments should be received from patients who are actually on the receiving end of the care. And that was done in this paper. And in this paper, among the optional treatments for COVID, for smell loss, this was pre-COVID, was the introduction of monoclonal antibodies as an option for treatment of these patients. Then we had COVID. Then we've had all this research. What has changed from what we've seen before? One of the first papers that was released following the onset of COVID and the spike in the number of patients with smell loss was released by the British Rhinological Society. And this was one paper that had two sections, one for primary care and one for secondary care. And what was expected when you presented to the GP, what GP is supposed to do, and when you presented to the specialist, what's supposed to happen. So that meant that there was an expectation for GPs to do something for these patients. And what was recommended is, after a waiting period, based off the fact that you expect most patients to recover their sense of smell spontaneously after the infection, to commence olfactory training if the loss of smell was lasting more than 2 weeks. And then the criteria for referral to ENT was if this loss of smell is persisting for greater than 6 weeks, or in patients who have had COVID, if it was persisting for more than 3 months. There was also mention of signposting of patients to resources of patient advocacy organizations such as Fifth Sense, Absent, and all the others. And I think this is very helpful because there are a lot of resources that the GP cannot discuss in a 10-minute appointment or in a 15-minute appointment that the patient can access. That's one of the things we found in this paper. And then with the global nature of the disease, we had a lot of global consortia. And this paper was released in 2020 by a research consortia around neurology, actually. And smell and taste was considered one of the areas that they wanted to evaluate. What I liked about this paper is there was a very strong showing of membership from low and middle income countries, and that manifested in the way the paper was written, including how psychophysical tests and smell testing can be delivered either remotely and with appropriate context-specific target odors and descriptors. And they mentioned the use of telemedicine and mHealth in delivering this care in areas where there's limited access. So this was very useful in that sense. In 2021, this paper, Professor Philpott had already spoken about, again, very clear outline for GPs and ENTs. What I found interesting here was that GPs were encouraged to carry out classical olfactory training. And if that did not work, then they were to refer to secondary care, and then ENTs to carry out modified olfactory training. And in primary care, smell testing is recommended. However, there was understanding that smell tests in primary care is still limited. If you look at the previous guideline by the British Rhinological Society, there was no mention of smell testing at all. And I think that's because that paper was written in the heart of the COVID pandemic, and with all the strain on resources, it probably didn't seem reasonable to recommend smell testing at primary care. So this primary care, was suggested do classical olfactory training, and secondary care modified. And in 2021, again, another paper from the US still making smell testing optional due to the resources required for smell testing. So there's something that's consistent about all the papers post-COVID. They know you do need smell testing. However, because of the resources may not be covered by insurance, may not be available or accessible, it was put as optional in these clinical guidelines. In terms of treatment, again, there's this waiting period, hoping that the patient recovers sense of smell. Doesn't, then you can commence olfactory training and or subsequently refer to ENT. The final paper I'm going to look at is not quite a clinical guideline, and this paper, it has a very strong showing of GCCR members as part of it. And one of the most important things I noticed in that paper was in terms of smell testing. They did mention that testing of one domain suffices. So in the past, the idea was you had to do at least 2 domains. Either you do threshold and identification or detection and identification. You know, you had to do more than one domain. But in this paper, they did say that for olfactory identification, for example, you've got to detect the odor and you've got to discriminate it before you can identify it. So strictly speaking, you have tested more than one domain. And I think that's useful for in terms of resources where you can use tests that you don't have to have so much equipment. You can just pick one test and have that in your clinic and use that. And in this paper, recommended early intervention as soon as you notice the smell loss. So the idea of a waiting period to watch and see if the sense of smell returns spontaneously on its own was not quite pushed in this paper. This paper encouraged early intervention in smell loss. And I think that that's an important thing as well. So in summary, what has changed? Number of tests. There's been so many new tests developed post-COVID, and there's been a lot of advocacy around testing in terms of coverage by insurance companies, legislation, more guidelines are recommending that you do it, including in primary care. And because of this, we're seeing more affordable tests being developed. So I am aware of one that's been developed by Monell, which is quite affordable. And I'm very excited about that. And I was happy to have an opportunity to try to validate that in Nigeria. And there's also a push towards early intervention. So at primary care, you can start and you should start classical olfactory training for these patients. And we see more variation now in olfactory training regimens. So we'll talk more about olfactory and modified olfactory training, which speaks to what Maria was saying earlier. I mean, the odors don't have to be the 4 classic odors. And having worked most of my life in a lower middle income country where many of these aromas were not native, you know, it's a bit difficult to try to get the 4 classic odors. But now knowing you can use, you know, a variety of odors for longer time than classic. So it's been greatly simplified. So it's easier to implement in primary care, and it's easier to implement in areas where there's a dearth of resources. In my personal experience, one of the things I have found is sometimes it's difficult to keep patients motivated in olfactory training. So after 3-4 weeks, if the patient doesn't feel like his sense of smell has, you know, come back, sometimes it's discouraged and not willing to continue. And I find it helpful to have a mentor or a buddy in places where you don't have organized patient advocacy groups or support groups, so that there's just one person who can check in and sort of keep the patient on the ball. And if it's affordable, and with the wait lists that have come around with COVID, if it's possible to organize a telephone appointment at intervals just to keep them motivated, that's very helpful. And if finally the world is a global village, you may not have a patient group in your country, but the resources are on the internet. GCCR resources are there. There's so many organizations that have their resources online that your patients can access. I'm very excited about the global collaboration that has come out of the COVID pandemic. And I think that it's very important in terms of growing the science around olfaction and developing guidelines and clinical approaches to patients that does not leave anyone behind. These are all the papers we have spoken about today, and thank you very much for having me.
Thank you, Google, for the nice presentation. Now we have a question from the chat box. The first one is from Tiffany. She asked about both speakers have spoken about the difference between people's responses and the clinical result for taste and smell loss. Does anyone knows approximately how closely related self-report data is to clinical results? Do you want to answer this question, or Professor? Oh.
I'm happy to give it a go, and then Professor Philpott can come in and add on to that. From what I have seen, I have not seen data that gives a direct, so it's different for different patients, and that's why it's so tricky. So you can have one person say, I've completely lost my sense of smell, and then you do an objective test and he does have just mild hyposmia, and then you have someone else that says, oh, it's completely gone, I can't smell anything. So it does vary. I haven't seen a study that's shown maybe it's usually 2 standard deviation below. No, I haven't seen that kind of constant figure, and I don't think that it is constant. I don't know if Professor Philpott has more to say about this.
Sorry, I missed the initial question. Would you mind repeating it for me?
Yeah, so the question is how closely correlated between the self-report data and the clinical result on smell loss and taste.
Okay.
Yeah.
Yeah, so I mean, there's a great graph in Richard Doty's Handbook of Olfaction and Gustation showing what comes into a smell and taste clinic, and in terms of patient self-reporting and what actually happens when you do psychophysical testing. And a large group of people kind of coming in, sort of perhaps 2/3 of people will say, I can't smell and taste. I see that very commonly in practice. And then we actually go to test people. A large sort of chunk of the pie is just people who can't smell. There's no taste issues at all. True taste deficits are about 1% of all clinic entrants. And in fact, there's a group of people who actually sort of do quite fine on testing. There's sort of probably about 1 in 5 people whose sense of smell on testing is okay. The only group where I find, and we published some work on this through our work on the macro trial, which is for chronic rhinosinusitis, when we're looking at the outcome measures we're going to use in the trial, and actually the correlation between smell and patient symptoms and other objective measures is quite good. And I think that's basically because patients have usually got a blocked nose as well, so they can roughly work out if their nose feels more blocked, then the likelihood is the smell is going to be worse, and they can use that as a kind of an anchor. But without that anchor, which is usually the case in other types of olfactory disorders, they lose that ability to kind of sort of work out where they are in terms of the olfactory performance, and we see huge variation between what people think they can do and how they actually perform.
Thanks, Dr. Philpott. So we got a second question from D. Piero. The question is, are patients treated for neuroblastoma with ERTC reported phantosmia? Are there any specific reasons?
I mean, these sort of intracranial tumors, are likely to be associated with disruption of olfactory pathways, and therefore, getting phantosmia and other related symptoms is not uncommon. So, I mean, interestingly, in all the years I've been running a smell and taste clinic, I've never seen anyone present primarily through the smell and taste clinic with any different forms of olfactory tumors. They usually present through other means first, but certainly, phantosmia and anosmia can be common sort of findings.
Thank you. And we have the next question from Dana. If no olfactory loss is detected after this further testing, what would be the recommended courses of treatment for complete loss of taste and flavor approaching 2.5 years of loss? I think it's for Dr. Breimer.
Yeah. So in terms of complete loss of taste and flavor, I am primarily an ENT, so I know more about olfactory loss, but I do know that you will definitely benefit from going to a specialist taste and smell clinic. And so this is why we are developing this directory. You're going to benefit from having a specialist focused on your condition. I suspect that it will be more of trying new therapy, but you definitely need to be referred to a specialist taste and smell center who can characterize the loss of taste. In this case, not likely to be flavor, since your olfactory function is normal, and they can dig more into that and see if they can try newer therapies for you.
Yep. And then we have another question. Has any progress been made or found for congenital anosmia?
Not really. I mean, there is animal research which has demonstrated the possibility of grafting olfactory bulbs, but I guess seeing that in terms of translation through to kind of human medicine is some way off yet. There is sort of early work around sort of olfactory implantation, and whether that's something that would be potentially of benefit to people in this group. Difficult to say at this stage, really. I think there's a lot of water to go under the bridge in terms of working out sort of, what options there may be for those particular group of patients. But yes, I mean, and there is variation within that group, because obviously, some have it as an isolated congenital loss, and some have it as part of a genetic syndrome. So yeah, I think there's a lot more of the science to be understood around that particular topic.
Yeah, my personal feeling, if you run a genetic analysis, you definitely show some extent of heritability there. And then we got a next question from Stephanie. There's been some good work on parosmia triggers. So has there been any new work on phantosmia as chronic conditions?
I mean, the trouble is, phantosmia isn't really a sort of condition in its own right. It's a symptom, and so it's a symptom we see within olfactory disorders. Sometimes it can be isolated, and occasionally I see the occasional patient that's isolated. But I think there's probably a broader question there about what are the treatments available for qualitative olfactory disorders, and the answer is, again, really limited good clinical trial data. It's mostly anecdotal stuff. Personally, I get trying things like gabapentin and other such agents can be sort of sometimes useful for managing these patients. But I know my colleague Matt Lechner at UCL has some funding to do some further study on parosmia specifically, but not so much for phantosmia.
So we still have 6 minutes. So I got a question for Ogogo. So you mentioned that in the GP in a clinic, there might be lack of resource to do a smell test. I wonder, is there a standard smell test to do in the clinics, or like used by the ENT? Like how much it really costs if it's gonna be using by GP?
So I think that the answer to that question would be very context specific. So what would be ideal for use in a high income country will be slightly different in other countries in terms of the cost. And then more importantly, in terms of the tests that are best suited generally to clinic settings for non-specialist clinics like GP clinics are ones that ideally can be done in a few minutes, quite quickly, and probably when the patient's in the waiting room before he goes in, or while he's with the doctor. So something that can be done, in a few minutes, not something that takes hours. Ideally, something that can be self-administered as well, so that you don't need extra staff to carry out this testing for you. So the kind of tests that usually are quick and can be self-administered and are relatively cheaper at the identification ones. But even those identification tests for many settings are considered quite expensive. I don't know all of them. There's so many, but the most popular ones are within the range of $20 to $30, which in some settings is not too bad, but for other settings is really, really expensive. But like I said, there are newer ones. I know about Sentinel, which is being developed by Monell, which is not expensive. and it's quite quick, self-administered by the patient as well. So something like that could potentially be easier to deploy in a GP setting, not too expensive, very quick. Patient can do it himself, and the doctor can see the results in real time.
Yeah, to be honest, actually, we have been using Sentinel to collect smell data in Australia, and I think it's quite easy to use. We just mail out a card, and so we send it to the COVID patients, and then they can just do it. I think you can finish a test in like 1 minute, and then I don't see any problem with people doing that test at home by themselves. So we got another question from Frank. Are monoclinical antibodies an effective treatment for long-term loss of smell and taste? I think it's from one of the Gogo's slides mentioned about the antibody treatment.
Yes. Okay. So monoclonal antibodies, they are an option in the management of smell and taste loss. And well, the data supporting their use in just quote unquote idiopathic smell and taste loss, and without any underlying conditions such as rhinosinusitis is not so convincing. So for the papers that are recommended, they're still considered optional, not recommended treatment at this time, as it happens to be for most of the treatment modalities at the moment.
Yeah, I saw Professor Philip also respond to that question.
Oh, okay.
MABs are good for chronic rhinology. Is it?
Sorry, that was me just saying, yeah, monoclonal antibodies. I mean, there's good evidence now supporting them in patients with chronic rhinosinusitis in the various trials that have been done to date. The trouble is, of course, that they cost £10,000 a year for a course of treatment. So certainly in the UK setting, I have real trouble getting access to those for my patients. The only way at the moment we can get access to them is to join another commercial trial and access a participating centre and recruit our patients to them. But yeah, we have to go through the respiratory medicine, and we have to demonstrate that their asthma is terrible in order for them to get treated for their chronic rhinosinusitis, which is generally rather fruitless, because often my respiratory colleagues usually sort of tweak their asthma medication, send them back to me. So I know in the US, obviously, I think monoclonal antibodies are much more readily available to patients, different healthcare sort of funding system, and I guess that there's probably a different philosophy around how they're seeing those work out in clinical practice. But the trial evidence so far has been positive.
Thank you. I think we are reaching a 1 hour webinar. So I'd like to thank both speakers for their time and everyone for joining this webinar. Maha, do you want to say anything before we say goodbye to everyone? All good?
Thank you so much for organizing, Jinguo. Thank you so much for speaking, Dr. Breiman, Professor Philpott. It's really good to see that there's progress in various domains. And, in the end, the story is, of course, not always super positive, because this is complicated. It's complicated to test, it's complicated to diagnose, it's complicated to treat, but there is movement in a positive direction, which I think is very nice to see. And it's because of all this effort in the past couple of years. So let's hope that this effort continues, and that people don't lose their awareness just because they lose awareness of COVID, because this is going to continue to be a problem. Anyways, I think everybody here is on the same page for this. But thank you so much for updating us. And thank you, Jinguo, for organizing. And everyone have a good day. And thank you for attending.
Many thank you to Carl Philip and Agogo, and also Maria and Daniel. Thank you. Have a good day. Bye-bye.
We'll see you guys in the next webinar.
Yeah. Yes.